Good afternoon. It's an honor for me to be a part of this mega event and to be sharing the stage with so many stalwarts in hematology. And I'm really grateful to Mindray for this opportunity. I'm going to talk about classification of anemias. And I'm not going to take you all through long lists of classification, rather an approach to how we can classify anemias. So when we talk about anemia, what is anemia? The reference ranges may vary, but basically when somebody has a hemoglobin that is low for his given age and sex, he or she is said to have anemia. There are few variations, but I will stick to the WHO reference intervals. So according to which any adult male who has a hemoglobin less than 13 grams, an adult non-pregnant woman who has a hemoglobin less than 12 grams is said to be anemic. And why do we use hemoglobin and not hematocrit to define this? Because I think hemoglobin measurement across all instruments and various technologies is very well standardized, making hemoglobin a better way to make clinical decisions. And anemia can occur, a low hemoglobin can occur due to various causes, could be hematologic, could be non-hematologic. So it's not really a disease, rather we consider it a symptom or a sign of some pathology, something underlying. So if we come to a classification, there are long lists of classifications, but a very basic one is an etiology classification. So anemia can, according to the cause, so anemia can occur if there's blood loss. The normal bone marrow can really increase the production of RBCs by many folds, 6 to 8 folds. But if the blood loss is fast, the marrow cannot make up, there will definitely be anemia. There could be a failure of the bone marrow, a proper failure, or because of some nutritional or hematinic deficiency, the marrow cannot produce properly, the marrow is infiltrated. So where we have an impaired RBC production as a cause of anemia. Another major heading is excessive RBC breakdown or hemolytic anemias. And hemolytic anemias, again, there's a long list. The causes could be inherited versus acquired. In inherited, we have defects of red cell membrane, hemoglobinopathies, enzymopathies, etc. In acquired, again, we say immune and non-immune. And in non-immune, again, we have a long list. So when we talk about classification in day-to-day practice, we want, when we come across an anemia, we want to put it in one of these classes so that we can come to the final etiology and patient can be managed accordingly. So a very practical approach, and well, in all branches of medicine, one has to start with the clinical picture. As pathologists, we would at least get some clinical features, and the age is important because if we are dealing with an anemia in the pediatric age group versus adults, our thought process will change. Again, in the pediatric age group, a neonat coming with anemia is perhaps blood loss due to blood loss delivery, or alloimmunization like RH immunization. An infant within 6 to 7 months, this is the time when hemoglobinopathy is present, because fetal hemoglobin normally covers up till about 6 months. So after 6 months, any presentation around that, we would think of a hemoglobinopathy. An older child, say a young girl of 12 years, just attained menarche, had heavy bleeds, and could easily present with iron deficiency anemia. So the age is important in an adult, and when we are dealing with an elderly person, we would think more of syndromes like a myelodysplastic syndrome. Presentation, if a person has a hemoglobin of 3, 4, even less, walks into your office, asks for a CBC, you know that this is something which is there for a long time. The body compensates, the heart rate increases, and various compensatory mechanisms kick in. And therefore, the patient would be tired, would be unwell, but would be walking around. So this also tells us that this is a chronic process and not something that has happened acutely. When an acute drop in hemoglobin occurs, these changes there's no time for these changes to occur. So the person will be, even with lesser degrees of anemia, will be more symptomatic. These features are all important when we try to, take into account some anemia and we try to classify it under one of the headings. Additional complaints, especially unusual complaints like an unusual thrombosis, will immediately pinpoint us to a specific diagnosis. And findings of icterus or jaundice plus with splenomegaly or lymph nodes, again, will change our whole thought process. This was the clinical features. And coming to the basic laboratory workup, we will of course start with the CBC. And the CBC with the differential will tell us about the anemia, about the degree of severity. Anemias like anemia of chronic disease usually is mild to moderate. So even the severity is important. And whether anemia is present with some abnormalities in other cell lines as thrombocytopenia or a leukopenia or leukocytosis with a flagging for an abnormal cell. Again, we will think of something else and will target investigations or at least plan in that way. Of course, the most important part in an anemia workup with the CBC is the red cell indices, which will classify the anemia as microcytic, normocytic, or macrocytic. And many times we have to, we don't have the clinical features are not clear. We finally fall down on this framework and then we decide our investigations. Along with the CBC, we get a red cell distribution width, which is an objective measurement of the degree of variation of the RBC size, which is often overlooked. And this can be really very informative, as I would like to show you in one of my cases. Added to this, a reticulocyte count, which doesn't come with a routine CBC, but we ask for it, which also gives extra information, and a blood film morphology. Most of the time when we have anemia, it will meet the laboratory's criteria for blood film review. So the blood film will tell us, again, confirm about the RBC morphology and findings, say, sickle cell, and we have a hemolytic process. We don't need to look further. So I don't want to exaggerate, but in most cases, I think the clinical approach with the CBC, looking at the RBC indices, red cell distribution width, retic, and a blood film morphology often gives us the answer. I could perhaps, stop my talk here. But so to sum up, we have these initial investigations, and depending on what we find from the initial investigations, we can do some basic biochemical investigations like bilirubin and fractions, haptoglobin, serum LDH. These would be deranged when we have hemolysis. Again, what is the cause of hemolysis? We could do a G6PD screen and iron studies and hematinics. These are almost routine investigations which will come in the second line. But sometimes even they may not help. Of course, there are situations where we have to even go to, gel electrophoresis to make a definite diagnosis of a RBC membrane disorder. We might even need to resort to flow cytometry to diagnose a disorder like PNH. Bone marrow examination with cytogenetics and molecular tests may become necessary. But it's always, again, I would like to reiterate, what we find right at the beginning will help us. We don't have to go through the plethora of investigations. We can make a more pinpointed kind of an approach. Without further discussion, let's go to my first case, a 7-month-old child with failure to thrive. Please note that the child is 7 months and there's already history of 1 blood transfusion. The hemoglobin was quite severely low and mild microcytosis. For that age, it's not too much. And there is hepatosplenomegaly. So 7 months, hepatosplenomegaly, anemia, and with a peripheral blood picture like this, microcytosis, hypochromia, target cells, 1 nucleated red cell, we would think of a hemoglobinopathy. Before doing any investigation, I would definitely ask for a hemoglobinopathy screen. Only confounding feature here was that the mother was insisting that she had been screened for thalassemia, so there was no chance that there could be thalassemia. But with this kind of a history and presentation, we still went ahead instead of looking at anywhere else. We did, and we found that the A2 was markedly raised with HPF. A2 can't be that high. It is HbE in that particular instrument. E and A2 elute together, and there's hardly any normal hemoglobin. So obviously it's either a homozygous situation or a compound heterozygosity for something. And it was finally the parental HPLC which proved that the mother had beta thal trait, father had HbE trait. So this child had a very serious hemoglobinopathy, which was behaving like a like a thalassemia major. And mother's history was that she had actually been detected to have a high HbA2 earlier, but somehow the laboratory failed to make the comment, and the consulting physician failed to look at the values. So that was another tragedy, another story for another day. So the age and the clinical presentation is definitely important. And we deal with one more child, 9-month male baby. Again, severe, very severe anemia. MCV is slightly raised. For that age, it is on the higher side. RDW is markedly raised. And we see that the platelets are also low, though the WBCs are maintained with a low retic. No splenomegaly, mild hepatomegaly is there. Severe anemia, there could be some hepatomegaly. So what could be the diagnosis? Could it be an inherited marrow failure syndrome, though the WBCs are okay? Could it be a hemoglobinopathy? There is no spleen. So anyway, while we are planning for the investigations, first thing we do is look at the peripheral blood film, which showed macroovalocytes in spite of the MCV being in the normal range, because there's quite a lot of variation in the size. Therefore, the MCV was in the normal range. So we were also thinking of an inherited marrow failure. So we did the marrow, and we can see megaloblastic changes and a lot of dysbiosis in the erythroid cells. And so concomitantly almost, the biochemistry was done, which showed that the vitamin B12 and the serum folate levels were normal, which was a little surprising. We were expecting that the B12 would be low. Iron studies were okay. But one interesting finding, because the child was in hospital, all the routine tests were done, and the child was detected to have diabetes mellitus. So this history was very pertinent, and immediately we thought of a condition known as thiamine-responsive megaloblastic anemia, where thiamine levels was low, may not even be low. It's because of mutation of a particular gene which encodes for a thiamine transporter. And it's autosomal recessive. So only in consanguineous, regions where you get a lot of consanguineous marriages, it's commoner. So, it is an important DD when we have megaloblastic anemia or pancytopenia in childhood with this appropriate family history and with normal B12 and folate levels. So while we were awaiting genetic studies, thiamine was started, just pharmacologic doses, and the platelets normalized within 2 weeks. And the last checked before this talk, his hemoglobin is stable, but I think lifelong this child would require thiamine. And other children also can develop sensory neural deafness. This child, thankfully, doesn't have that. There are a lot of papers on this. It's a well-known entity. So again, the history was pertinent, and the finding of diabetes. So we could straight away, without doing too much more investigations, we could straight away ask for the expensive gene mutational analysis. And then when we look, there is, of course, we can see this vacuolization of the erythroid precursors, which is also a feature of dysbiosis. And there is some amount of dysbiosis even in the myeloid series, and very much in the megaloblastic, in the megakaryocytes. And it is well known that there are some papers which say that we should call it thiamine-responsive myelodysplasia and not just megaloblastic anemia. So when we are talking about megaloblastic, of course, this is a rare case, so I wanted to share with all of you. And when we are talking about megaloblastic anemias, let's have a look at this young female who was a nurse in my previous hospital, who presented with severe anemia and weakness. Again, you can see that the retic response is not there at all for the degree of anemia, and the MCV is normal. MCHC is slightly on the higher side, and there is pancytopenia. So we have pancytopenia, reticulocytopenia, and but MCHC is slightly raised. So I would probably pancytopenia with a low retic, I would think of aplastic anemia too. But I didn't show you the RDW value purposely. So when we have an RDW that is so raised, so we know that even if the MCV is in the normal range, there is a lot of variation in size, and the peripheral blood film showed some classical macroovelocytes. We weren't too worried, and we knew we are dealing with the vitamin B12 or folate deficiency as proven. Please note that serum LDH can be raised in any hemolytic anemia, and in megaloblastic anemia, there is ineffective erythropoiesis as well. So there's a contribution as well as some amount of fragmentation. So serum LDH is expected to be raised. So then there were classic hypersegmented polymorphs with more than 6 lobes. And there I think this audience knows the definition of a hypersegmented poly. And what I wanted to highlight is that in megaloblastic anemia or even iron deficiency, RDW is often the first parameter to be deranged. The MCV is just an average of size of all RBCs. So if there's a megaloblastic anemia with iron deficiency, or even a pure megaloblastic anemia, there is some amount of fragmentation because the megalocytes, what we say, the large cells, their lifespan is a little shortened. So when there is severe megaloblastic anemia, this fragmentation can increase and the MCV can fall into the normal values. So the MCV has no meaning if we miss the RDW. So we can have macrocytosis due to non-megaloblastic causes. Liver disease is very well known. We may see other telltale signs of liver disease like target cells, spur cells, but usually in the non-megaloblastic type, the cells are more round instead of the classic ovelocytes, and the RDW is often low, suggesting that the whole population is a more homogeneous population. We can have artifactually raised RBC size too in some situations because of the way the instruments measure the size. And RDW is important, we all know, in the differential diagnosis of microcytic hypochromic anemia as well. And it is markedly raised in the nutritional anemia and not so in thalassemia trait. And talking about iron deficiency, talking about investigations, this was a 38-year-old female who had severe microcytic hypochromic anemia with an RDW raised with a peripheral blood film that looked like it, and a history of menorrhagia. In such a situation, we may not even investigate further. We may not even do the iron studies and start therapy. While a similar situation with a lesser degree of anemia in a 40-year-old male who actually presented to our lab with iron deficiency, with no history of bleeding, he eats well. In this situation, just saying that there's iron deficiency is not sufficient. Even as laboratory personnel, it is our job to tell them to go further. And if no obvious cause, one must look for a cause of iron deficiency. In this case, this man was lucky. He underwent a hemicolectomy for a CA colon, and there's enough evidence to say that even occult blood in stools is not sufficient. A full GI workup is strongly recommended depending on the clinical situation. And these are the traditional biochemical parameters for iron deficiency. Serum ferritin, we all know, is a known inflammatory marker, and when there is inflammation, things can be problematic. And more often than not, we deal with this kind of a situation, elderly or even young, having little microcytosis, RDW plus minus not so much increased, and serum iron studies are not very helpful. And here, of course, this particular patient had a mildly raised serum creatinine. So this is what is classically anemia of chronic disease or anemia of kidney disease, chronic kidney disease. they're very closely related. Even without kidney disease, one can have anemia of chronic disease. And we know quite a lot about the pathogenesis today. But abnormal iron metabolism, because of a molecule called hepcidin, which is released in response to the inflammatory markers, leads to a block in iron transport across cell membranes. So the iron present in macrophages will remain blocked, and there won't be intestinal absorption either. And this is the major pathogenetic, a mechanism of anemia of chronic disease, and even anemia of kidney disease. Hepcidin levels are high because of the kidneys fail to excrete it, and there's some inflammation. EPO is low, so these two are very closely related situations. Actually, in a day-to-day basis, we see them more often. And the ferritin and others may not be helpful. Newer parameters like the reticulocyte hemoglobin expression measures a hemoglobin equivalent in the retics, which tells us if the erythropoiesis that is happening at that point of time is iron deficient or is replete with iron. So these parameters like soluble transferrin receptors, not done very often, might be helpful. But really, anemia of chronic disease is a very difficult chapter and a whole long chapter by itself. But I would encourage you all to read the guidelines. These are even newer, and they make things very clear. And but still, it is a complicated issue. When we are in this realm of microcytic anemias, I would, again, my next case is a 60-year-old male whose CBC was sent to the lab. And because the hemoglobin was low, again, the slide review criteria was met. So we looked at the slide. There was microcytosis, and we saw a lot of basophilic stippling. And with the microcytosis and quite a severe hemoglobin, and RDW not that raised for the degree of anemia, microcytosis is not that severe, and with basophilic stippling, we went to find out more and found out that the patient had been admitted suspecting some CNS issue because he had some confusion. And because we gave this pertinent findings, more history was sought, and it was seen that he had history of quite severe constipation. So lead levels were asked for. We know that lead poisoning also is associated with microcytic hypochromic anemia, and basophilic stippling is a very characteristic finding. So it's a combination of the history, the microcytosis, and the peripheral blood film, which led us to help the clinicians come to the proper diagnosis. And the proof of the pudding is in eating it. And this patient really improved with chelation therapy. Very rapid improvement he showed, at least in his confusion. But all microcytosis and hypochromia is not necessarily a thalassemia or iron deficiency. This was a 10-year-old child in my present hospital who had all this microcytic hypochromic indices with raised RBCs and with normal iron. Hemoglobin HPLC was normal. Platelets were raised. So iron studies were done thinking this could be iron deficiency. But you can look at the peripheral blood film and see so many small RBCs, fragments, poikilocytes, which are most probably causing an artifactual rise in the impedance platelet count. And after we saw the blood film, we found that the patient also had a little splenomegaly, and the retics was raised, was added later on. There was a family history of a membrane disorder. So just based on morphology, they're all, this is hereditary pyropoikilocytosis. A less severe form, or you can say a brother, is a hereditary elliptocytosis. This was an adult male with an MCV that fell in the normocytic range. Retic is raised, which suggests, and the indirect bilirubin is raised. Haptoglobin is low. So all this suggests that there is a hemolytic process going on. This patient also happened to have heterozygosity for sickle cell disease, sickle cell anemia, HBS. But this does not explain his, he has had jaundice on and off and history of gallstones. So all this points to quite a hemolytic process, not so usual with a HBS trait. And but the peripheral blood film, for some reason, nobody had looked at the peripheral blood film, showed elliptocytes. And these are all related. This is a hereditary case of hereditary spirocytes, spirocytosis. Again, MCV is sometimes can be macrocytic because of reticulocytosis. They appear so large. And MCHC may be a little high. The spirocytes are a little dense, retics are raised, and the Coombs, it's important to show that the Coombs test is negative. Now, there are a lot of guidelines as to how to investigate these cases. But if we get a peripheral film like this, there is a positive family history because most of them are autosomal dominant, and we get the characteristic findings of hemolysis. I don't think we need to proceed further. There are guidelines. I would again encourage you to see these guidelines, which talks about the ones where you need to remove the spleen and the ones where you should not. And what about osmotic fragility? We all know that spirocytosis means we should do an osmotic fragility. Osmotic fragility basically only tells us how much the red cells can expand when they're exposed to or when saline enters the red cells. So it will only tell us about how much of extra membrane is available for the red cell to expand. So basically, it is only confirming if an osmotic fragility is increased. It only confirms that there are spirocytes. So when we have already seen spirocytes, osmotic fragility manually or even by flow cytometry will not add anything extra. Sometimes, of course, there are borderline cases, and diagnosis may be very difficult. Then when we have to resort to even SDH gel electrophoresis for red cell membrane studies. I mean, those are the confirmatory tests, maybe even genetic studies. But I would encourage, for lack of time, I would encourage all of you to go through these guidelines, which make things as clear as possible. And again, similar findings. The picture looks the same as the last one, but in a different age group. A 55-year-old female will have totally different connotation, and true enough, Coombs test was positive because in this age group, we are thinking more in terms of an autoimmune hemolytic anemia. Spirocytes are formed whenever membrane is lost. So even membrane disorders, and here membrane is lost because immune complexes get deposited on the membrane. In the passage through the spleen tries to remove these immune complexes, and small portions of the membrane are lost. So spheroidal shape is a shape that can accommodate maximum volume for the least amount of cell membrane. So it's a very non-specific finding. But again, in this age group, if we find an autoimmune hemolytic anemia, one should not again stop there. One should at least do a careful peripheral smear examination for any atypical lymphocyte, because chronic lymphoproliferative neoplasms are very commonly associated with autoimmune hemolytic anemia. This is a case of CLL, which clearly shows spirocytes with, polychromatic macrocytes. So CLL with stable counts may not require treatment, but when a case of CLL develops anemia and thrombocytopenia, treatment may need to be started. But here, truly speaking, in this particular case at least, one can confidently say that this anemia and thrombocytopenia is because of an autoimmune process, because of the morphology, and the patient probably will still manage with just steroid therapy without having to resort to anti-neoplastic therapy. When, again, we are discussing hemolytic anemia, so the hemolysis we talked about previously was mainly extravascular, occurring in the spleen. And there are some features which are very specific for intravascular hemolysis, like hemoglobin urea. This was a 22-year-old male who presented with a hemoglobin of 8.4 grams, but he was very symptomatic, which means that this has developed acutely. He also gave the classical history of dark-colored urine. Coombs was negative. We would do it routinely. There was mild icterus, so there was no doubt that he's undergoing hemolysis, and that to intravascular hemolysis. So we would definitely think about a G6PD screen. Also looked at the peripheral blood film, and we can see what are known as blister cells, which are very characteristic of any oxidant damage. And though the G6PD screen was negative, the patient gave a history of malaria and treatment for malaria. So we were very confident in saying that this is nothing but a G6PD deficiency. And true, when G6PD was repeated after the reticulocytosis abated, we picked up that a low G6PD level. This happens because we know that young cells, and particularly retics, are rich in all red cell enzymes. So when we look for G6PD levels in young cells, they may appear normal because all the old cells are already broken down. And just for comparison, I have shown you another patient's peripheral blood film. He had dapsone toxicity. Again, there was oxidant damage. We see the classic blister cells. And this, when a portion of the membrane is bitten off during its progress through the spleen, it gives this appearance of these bite cells. These are called bite cells, as if a portion has actually been bitten off. So these are so with a combination of hemoglobinuria, raised retic, and a combination of a peripheral blood film characteristic finding, we can definitely at least say that there is oxidant damage leading to hemolysis. And another important category of intravascular hemolysis is microangiopathic hemolytic anemia, which can occur in many situations. But of this, TTP can be life-threatening. Thrombotic thrombocytopenic purpura, where the platelets are low and the LDH would be raised markedly. And in the ACT clinical scenario, this should be kept in mind, because without treatment, even today, TTP has a fatality rate of almost 90%. And as laboratricians, even if we have the slightest doubt, we should raise the alarm. Though, in prosthetic valves or even DIC, we will see some fragmentation. In DIC, even the platelets may be low, but it's here, at least I think it is better to err, at least to, even put the clinicians on alert, better to err on the, positive, because you could be dealing, we are talking about life and death here. Then there are some unusual histories. This is a real case scenario, an 18-year-old boy who presented with pancytopenia, severe neutropenia, severe reticulocytopenia, and a hypocellular bone marrow, and was actually diagnosed as aplastic anemia. And he was admitted for therapy for aplastic anemia, ATG therapy, in the hospital when workup was being done, and he showed no other, feature of, there was no spleen, the retic was low, you could see, but he suddenly passed dark-colored urine, and the urine was positive for hemoglobin. Subsequently, when the LDH was done, it was raised. So here we have a classical case of bone marrow failure. This was proven within days, presented with intravascular hemolysis. This can be nothing else but paroxysmal nocturnal hemoglobinuria. These pictures, I couldn't put my own flow plots, I couldn't get, but these pictures are just given for representation. So in paroxysmal nocturnal hemoglobinuria, it's a clonal, but yet it's an acquired disorder where there is loss of certain anchor proteins on cells, RBCs, WBCs, neutrophils, and monocytes. And we look for those anchor proteins, or we look for the absence of those anchor proteins using flow cytometry. This particular case, at that time, we didn't have flow. This is way back from my New Delhi days. This patient, we did a HAMS test, which was positive. But I think nowadays flow cytometry, you can at least send the sample away. PNH is characterized. It's very, very unusual or very classical features of hemolysis and bone marrow failure, and even thrombosis, especially thrombosis in unusual sites. And here I would like to talk a little bit about urine hemosiderin, because in PNH and some chronic disorders where the hemolysis is not there at the moment, but there has been hemolysis in the past, urine hemosiderin is a useful and very simple test. We concentrate or sediment the urine, look for presence of iron there, because if there was intravascular hemolysis and there was hemoglobinuria in the past, the renal tubular cells will absorb that iron, and when they're sloughed off in the urine, they will give a positive test for iron. So when you don't find features of hemolysis, and retic response will be blunted because there is marrow failure. And then this urine hemosiderin, in that particular case, if we had looked for it, perhaps it would have been positive even before he developed overt hemoglobinuria. And then talking about some anemias when we really need to jump, this was a 50-year-old male who complained of tiredness. This was his major problem with an MCV, which is borderline high 99. And all the other counts are normal. But what we see is rouleau formation and a lot of blueness in the background. So he's just come for the CBC. So one should immediately, in such situations, even young people can get multiple myeloma. One should be very, very alert, and without wasting much time going for, B12, folate, waiting for that, I think we are justified in jumping to some more investigations. And true enough, in the routine investigations, the routine liver function test showed that the globulins were raised, and the serum creatinine was also mildly deranged. So straight away, from the peripheral smear, we asked for a bone marrow straight away, which showed atypical plasma cells. Then the monoclonal proteins were also picked up subsequently. And again, this is a 69-year-old male whose main complaints was that of anemia, tiredness. So his hemoglobin was low. WBCs was slightly low. Platelets were also borderline. But otherwise, there was nothing remarkable on the peripheral blood film. RBCs look normocytic, normochromic, and nothing very striking. But this neutrophil seems to show a little abnormal segmentation. And when we looked more based on this, there was definitely a abnormally segmented neutrophil. The nucleus looks so mature, chromatin, but there is no segmentation. Immediately, we looked back at his history and saw that his WBC was always around 4,000, 3,900. On the lower side, platelets about 1.5 lakhs. So here we went straight for the marrow, which showed dyspoiesis, mainly in the erythroid, and some amount of hyposegmentation in the, enough to say that at least 10% of the neutrophils also showed hyposegmentation. So there was bilineal dysplasia, and clear here, and iron stain showed ring sideroblasts. So when we are dealing with an anemia and we are having to resort to bone marrow, then one should not forget the iron stain. One, it will tell us about the stores, and it will tell us about presence or absence of ring sideroblasts. Presence of ring sideroblasts means that there is this erythropoietic process, and per definition, the granules have to be distributed perinuclearly, and at least 1/3 of the nucleus should be encircled. They fulfill all the criteria. In this case, almost 35% of the erythroids were ring sideroblasts. So this was a case of refractory or myelodysplastic syndrome with multilineage dysplasia. So the presenting complaint was just anemia, but we had to go right up to bone marrow. I would like to summarize here that to classify any anemia, the clinical features itself may really play a huge role. And the basic labs will start with the CBC, reticulocyte, and a peripheral blood film. CBC will tell us if there's only anemia or there's anemia with abnormalities of the other cell lines, as we saw in my last case. And the CBC will also help us to classify the anemia according to morphology. Sometimes other things may not help, then we may just have to, our starting point may be just from the RBC indices. RDW added to this is very helpful, especially when we have a normocytic, normochromic anemia, but the RDW is raised. it will point to us that there is a small population of maybe macrocytes or microcytes. So RDW should not be forgotten. A reticulocyte response, if it is adequate, if it is raised for the degree of anemia, means that there is blood loss or RBC breakdown. And if we are suspecting RBC breakdown, there are some features of red cell breakdown like raised bilirubin and raised serum LDH, low haptoglobin. Again, hemolysis can be intravascular and extravascular. There are some features which are particular for intravascular hemolysis, like hemoglobin urea, raised plasma hemoglobin, and urine hemosiderin when we have chronic intravascular hemolysis, but which hemolysis may not be present at this point. Then urine hemosiderin, a very simple test, but very useful. And an inappropriate retic response to the degree of anemia means the marrow is not really responding well. Could be nutritional deficiencies, could be a pure bone marrow failure. Anemia of chronic disease also, there's a component of marrow failure. And we would think in those lines. Sometimes, in spite of going through all these in details, we do need to resort to a bone marrow. We do need to resort to a specialized assay like flow cytometry for PNH, or we may even have to do some genetic tests to come to a definite diagnosis. Thank you very much for giving me hearing, and I look forward to answering any questions.